Hi, I'm Attorney Ramsey Bahrawy, and this is Your Money, Your Life. Today our topic is understanding Medicare. Assisting me in this discussion is Dr. Tanya Feke, a board-certified family physician and author. Her book, Medicare Essentials, A Physician Insider Explains the Fine Print, has remained an Amazon bestseller. Her most recent book, entitled An Idiot's Guide to Medicare, is expected to hit shelves in April 2015. Dr. Feke's passion for patient advocacy and education extends to her website, diagnosislife.com, which is a resource for patients to support their health and well-being. Dr. Feke also services her community by working at Convenient MD, a New Hampshire urgent care clinic. And best of all, Dr. Feke's ultimate goal is to help people get quality health care for the least cost. Dr. Feke, welcome to Your Money, Your Life. It's great to have you on the program.
Thanks for having me.
Now, a lot of people are confused about what is Medicare, what is Medicaid. What is the difference between Medicare and Medicaid?
Okay. It's frustrating for a lot of people because the names, the titles sound very similar, and it's easy to get them confused, but they're both run under the same government agency, but they're two very different programs.
Okay.
So Medicare is health care programs and invested mainly for the elderly, so those over 65 years and older, or for those who have disabilities. Whereas Medicaid is a health care system that is offered to those who have low income.
Okay.
Some folks may actually be appropriate candidates for both programs.
True. Okay. Now, does somebody automatically qualify for Medicare, or is there some sort of enrollment process that they have to go through?
That's one of the tricks of my books.
That's one of the tricks, yeah?
Yeah, some folks are automatically enrolled and others are not. And it can be very tricky because if you don't enroll in the proper timelines, then you'll pay for it, literally. There are penalties, fees, that Medicare will give you, and they may last years and years and years. So trying to let people know when those enrollment periods are makes a world of difference. So to start that off, I would say most people when they turn 65 years old will become eligible for Medicare, but that doesn't mean they're automatically enrolled.
I see.
Yeah.
So there's eligibility versus enrollment.
Yes.
So once you become eligible, you have to enroll, or do you have to enroll before you become eligible?
Okay. Well, you become eligible 3 months before your 65th birthday.
I see.
Okay, and then your initial enrollment period extends 3 months beyond your 65th birthday. So essentially you have a 7-month window of time to enroll. But, there's always a but with the government.
Okay.
If you are already receiving Social Security benefits for some reason, you'll automatically be enrolled during that time without having to take action.
Okay.
If you are not receiving Social Security benefits yet, you will have to actively enroll or otherwise face late penalties.
Okay. Let's talk about these penalties. You alluded to them earlier, and just now you mentioned penalties. How significant are these penalties, and how careful do people have to be so they are not penalized?
It can be a lot of money. Some folks can pay thousands and thousands of dollars beyond what they would over the course of their Medicare experience if they're not aware of the penalties. And it depends, each part of Medicare, and Medicare is divided into 4 parts, A, B, C, and D, has its own penalty, of course.
Oh, really?
So you'll pay for each part that you're eligible for but didn't sign up on time.
Okay.
So.
Okay, so let's talk about the 4 parts to Medicare. First one is Part A. What is Part A, and do people have to pay for Part A?
Part A, most people do not have to pay for Part A. Folks who have contributed enough in their employment taxes over the course of their lifetime, it's not in dollars that it's measured, but it's in time. If they have committed 40 quarters or 10 years worth of tax employment towards Medicare, their Medicare A will be free.
Okay.
Okay. But for anyone who has not donated or given as much from their employment experience to that, they may have to pay premiums, and that will be determine the amount of the penalty.
Now, are those premiums paid by the individual directly to the government?
Yes.
Yes. So
Yes.
you write a check every month.
That's right.
Okay. And what does Part A cover? What types of treatment does it cover?
Part A is what we consider hospital insurance.
I see.
So when you're admitted as an inpatient, and that's an important distinction, then it will cover your hospital costs. So tests, the bed that you stay in, it covers everything in the hospital except for your doctor care.
I see. Does it cover something like hospice, which is
Yes.
inpatient?
A contributes to hospice, yes.
It does.
It does.
Will it pay for some forms of at-home care?
It does.
It does. Okay. All right. Part B. What is Part B? What does it cover?
Part B is kind of like your bread and butter of Medicare. It's where most of us live, because we all hope that we don't end up in the hospital and need to use Part A.
True.
Part B is your outpatient visits, your doctor visits, your regular blood tests, preventive screening exams. It's pretty much almost everything else except for medications. Medications that fall under Part D.
I see. And is there a premium that a person has to pay under Part B, as in boy?
Yep. Everyone pays a premium for Part B. Part A, some folks can get for free, depending if they worked enough. Part B, doesn't matter. Everyone pays a premium.
Now, are any of these premiums at all affected by the individual's income?
Absolutely.
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 Tell us about that.
And they use your tax forms from 2 years prior to determine who will pay a little bit more than the baseline amount.
Okay.
Folks who have an income of less than $85,000 a year will pay one set amount, and then there are 4 brackets increasing progressively, and there's an added amount to the premium for each of those brackets.
And this is for Part B only, or is it for Part A also?
That happens to D and B,
D
but
and
not
B.
A.
No.
See, the government tries to make things confusing, so.
Well, that's why we're doing this program.
Exactly.
That's exactly why we're doing this program. Okay, so we've talked about Part A, we talked about Part B and what it covers. What is Part C?
Part C is optional. And it's a nice option to have, because usually we don't get a lot of options when it comes to the government. A and B together, when we put A and B together, that's considered original Medicare. So when Medicare first started back in the 60s, those were the 2 parts that existed. There was nothing else. And meant to cover your hospital and your outpatient costs together. It doesn't cover everything. And a lot of folks found that, and it can be very frustrating. Common things it doesn't cover: eyeglasses, hearing aids, dentures, a lot of things that you need as you get older.
Absolutely, and it doesn't cover any of those.
None of them.
Wow. I mean, as you get older, your eyes fail and your hearing fails, and it doesn't
And all
cover
of those
that.
things also increase your risk for falls, which then lead to more hospitalization. So it's really quite ironic that they don't want to protect those things that will actually help prevent further costs down the road.
So does Part C potentially cover those things?
So what Part C is an alternative to original Medicare. So you can take A and B, or you can take C. You can't have both.
Okay.
C is under the umbrella of Medicare Advantage. And Medicare Advantage plans will cover everything that A and B covers, plus some. But you'll pay an extra premium for that.
It's my understanding that the companies that are involved in Part C are private companies.
Yep, the government makes a contractual agreement with the insurance companies, private insurance companies, to make sure, one, they do cover everything that's an A and B, and then the government actually pays those insurance companies a certain amount so that they can offer those plans to the public.
So the government actually subsidizes Part C. is what you're
Exactly,
saying.
yep.
Okay. Now, President Bush signed a bill into law that brought about the 4th part, Part D. And as you mentioned earlier, that's the prescription plan.
Yes.
How does Part D work?
Part D is very convoluted.
Okay, let's talk about it.
But it's a very important piece, because a lot of seniors are on medications. The average senior, 70 and older, has at least 5 prescription medications. And when they look at non-prescription medications, may be on as many as 10 medications at a time. So the cost of medications without being part of original Medicare was really overwhelming to many folks who are on a very limited income. So I think that Medicare Part D came in at a good time, and it was about time that it did step in and help people out. But it's very confusing for people to understand. It's optional, so whereas if you get A or B, you got to get those. You can get A and B, or C, and then or D. So C and D are optional, A and B are, you got to do it. So with Part D, you sign up similar to Part B. I know the letters just kind of start to get jumbled up. Right. You will pay more if you earn more in your income for your monthly premiums. But there's a lot of private insurance companies that offer you different plans, so you have to shop around. Right. Find the plan that's going to cover the medications that you're already on, and hopefully the medications that your doctor may anticipate you may need in the future. Because it would be very frustrating if you picked a very simple plan, say, had 10 medicines on it. There's no such plan, but just for simplicity. And then the doctor's, well, you need 15 medicines now. And if there's 5 medicines they're paying out of pocket, you know. So you can save money by getting the cheapest plan, or you can get a more comprehensive plan, kind of hoping for that'll cover your needs in the future.
Now, it's also my understanding that under Part D, the insurance companies are all private insurance companies.
Yes.
And they pretty much bid for people's dollars, so to speak.
Absolutely, yep.
Okay. Now, there's also something under Part D called the donut hole. What is the donut hole?
The donut hole is a very confusing thing. This is, I mean, the
is it
idea.
Some sort of black hole? What is it?
It essentially seems like a black hole. Yeah. What it is the government saw that if they just spent all this money on drugs for seniors, they might lose a lot of money. So they wanted to kind of put a cap to it so it wouldn't get out of control. And a lot of that came to be because a lot of pharmaceutical companies, it's brand name medications, which cost a whole lot more than the generic versions of those same medications. So the idea of the donut hole came to kind of cap spending. The idea was you and Medicare, so the beneficiary and Medicare, the government, would pay up to a certain amount with the initial agreed upon plan. So you'd pay a copay, $6 per prescription, say, if that was your plan. But after that amount of money has been spent, they're not paying that anymore. And so the beneficiary goes to this period of time where they're paying the bulk of their prescription medicine costs. And then once they spend a whole lot, they go into what's called catastrophic coverage. That means the government realizes they may just spend too much, and then they start paying again. So there's a hole. Where they pay, they stop paying, and then they pay again.
Can you tell us at what number under Part D they stop paying? Are we talking 1,000, 2,000, 3,000, 4,000?
At this time, it's between the $1,700 and $1,900 range of spending.
I see. After, let's say, $1,700 or $1,900, you're pretty much out of pocket.
For the most part.
Okay.
I mean, they do pay a proportion, but a much less proportion than they were paying initially.
Right. And then when you reach what you refer to as at a catastrophic level, then they'll start paying.
They'll start paying again.
Okay. Yeah. Has Obamacare in any way affected any of these parts, Part A, Part B, Part C, or Part D?
Well, Part D especially.
Especially Part D?
Especially Part D, in a good way.
Okay.
In a good way. The donut hole was even bigger when it first came into place, and Obamacare has helped to kind of shrink that donut hole, so there's a lesser amount of time that seniors will have to pay out of pocket. So is it ever going to be 100% no donut hole? Doesn't look that way. But by 2020, it's going to be much smaller. It's going to be more like a munchkin.
A munchkin, huh?
Instead of a whole donut,
Okay.
you know? Other things that Obamacare has contributed to, it has helped a lot with preventive screening. It's added a lot of preventive screening opportunities to seniors that had not been offered for free previously, that are now offered for free. And I think that is a valuable resource, but a lot of folks misunderstand what some of that screening is, and it can be very confusing.
So what is that screening?
Well, screening, first, one of the things they do is called the annual wellness visit. And a lot of people mishear the term, and they hear annual wellness exam. It is not an exam. The doctor is not to do an exam.
I see.
It's more a consultation. And that leads to a lot of confusion. Folks come in demanding their exams, and you're like, I can't do an exam because it's not part of the visit. You don't want to be penalized as a provider for not doing the things that they're very strict about you doing. So it makes it a little tricky sometimes. But at the visit, they pretty much, the doctor and the patient sit together, and they kind of go over, you know, are you a candidate to be checked for diabetes? Let's check your cholesterol, and all different things that can help prevent long-term problems.
Okay.
And also including lots of cancer screening tests.
I see. Oh, that's actually good.
That's good.
Because you're actually getting ahead of the curve here, right? You're trying to figure out if there's a problem and then address it earlier rather than later.
Exactly.
Right.
And the annual visit is free to beneficiaries. So if they, choose to take advantage of that visit, there's no cost to them.
Okay, so the beneficiary doesn't pay, but somebody must be paying the physician.
The Medicare is still paying the physician.
Okay. All
Yep.
right. All right. So that's a freebie from the government. That's pretty good.
And once in a while, they throw us a bone.
Yeah, I guess. Wow, that's pretty good. I honestly didn't know it was free.
That is free.
In any other ways, rather, does Obamacare affect any of the Medicare parts?
This part specifically, otherwise, there's one kind of indirect way. And Part A is a tricky bugger. Part A costs the government a lot of money. When someone is in the hospital for an extended period of time, it costs a lot. Because the way the government pays for Part A is the patient, the beneficiary, will pay one flat deductible for up to a 60-day hospital stay. So if they stay 3 days or 60 days, they're paying the same amount. They're going to pay about $1,600. That's about it. But if they're there for 60 days, the government's going to pay a lot more than $1,600 to the hospital. So they wanted to change things a little bit so they can minimize how long someone's in the hospital, and they also wanted to change it so maybe they didn't want to use Part A to pay for some hospital stays.
Now let's talk a little bit about long-term care in a nursing home. A lot of people are of the belief that if they go into a nursing home for long-term care, they'll be covered by Medicare, but that's not the fact, is it?
That's not even slightly true, which is very unfortunate because that's what a large population of our elderly, citizens need, is long-term care. Dementia is on the rise, Alzheimer's disease is on the rise, and people suffer and families can't keep up with it.
Right, and it's very expensive.
It's very expensive. Actually, in my book, the Medicare Essentials, there's a little statistic in there. It says the average nursing home, once you get stuck paying out of pocket, it costs about $80,000 to $100,000 a year for a shared room.
Wow.
In a nursing home. Most folks do not see that much in a year anyway.
Right.
So how are they going to do that long term? And it breaks families. This is terrible.
It does, and of course, we started off the show with what's the difference between Medicare and Medicaid. If you qualify for Medicaid, and of course there are daunting qualification requirements for Medicaid, Medicaid will pay for long-term care.
They will.
But you've got to make sure you meet all of their regulations, and as I said, it's daunting.
It
and
is.
Most people really don't prepare for Medicaid.
They don't, but most folks do end up on Medicaid in order to stay in a nursing home. That's the majority of the way. They burn through all their savings. They burn through everything.
Burnt down through them. Yeah.
They burn down everything, and then they qualify.
I mean, yeah, the threshold is if you're not married is $2,000, and if you are married, it's $119,000, which is not a lot of money either.
It's hard.
Yeah.
It's very hard. The one time that Medicare A will help pay for some nursing home stays is after an inpatient hospital stay.
Okay.
They'll pay up to a certain number of days. The first 21 days are free, and I believe it's up to 90 days. You will pay $210 a day, and then after that they don't pay anything else.
Now you mentioned earlier Medicare copays. Would you talk a little bit about what copays exist under Medicare and whether any deductibles exist under Medicare?
Sure. So Part A, I'll kind of tackle letter by letter.
Okay.
So Part A, your deductible, you pay a deductible for each hospital stay, and that's just a flat rate. So that's more straightforward. So you'll pay that, like the number will change every year, but it's around $1,600 on average, and you'll pay that for an approved hospital stay each time you're hospitalized.
What does approved mean?
Yeah. Some folks, they're in the hospital and they will stay overnight, and they think that they're labeled as an inpatient, but they're not. They may be labeled as being under observation.
I see.
And this is a very, very big issue. Last October, well, 2 Octobers now, it's 2015, so October 2013, a new law came into place which has been nicknamed the 2-midnight rule. So unless you stayed in the hospital a period of time where you crossed 2 midnights, you could not be considered an inpatient. And so this left a lot of people thinking they were being covered, but instead of the deductible being paid from Part A, they were using Part B to pay for that hospital stay, which cost them a lot more money out of pocket.
Is the deductible higher on Part B?
It's a little different in principle. So for Part A, you pay the deductible for a flat hospital stay no matter what. So it's fixed. For Part B is confusing because each individual service you received, you're billed for, instead of there being a lump payment. So you usually pay 20% of each thing.
I see.
So that adds up really quickly, and quickly in a hospital setting, if you're there for a couple of days, crosses that $1,600 threshold.
Right, right.
So that's where, especially if someone's there for a long period of time, you want it to be covered under Part A because it's cheaper for you.
Okay, so what you're saying is that hospitals, because of a change in the law, are required to not categorize a patient as inpatient if they haven't stayed in the hospital for a certain period of time.
Okay.
Is that correct?
That's correct. And there's one little exception, and this is the most important thing to probably share with your viewers, is unless. There's always an unless. So the law talks about the 2 midnight span. If someone crosses 2 midnights, but they're there kind of twiddling their thumbs and nothing's happening, Medicare is still not going to pay because they don't think it's medically necessary for them to stay.
Okay.
But if a doctor sees that a patient looks really ill when they come in and they really think it's important that they need to be in the hospital, this can't be done anywhere else. The perfect example is like an appendicitis. If you don't take it out, someone could die.
Right.
And most people go home the very next day. Well, they're not going to cross 2 midnights, So, but it was a life-saving surgery. Right. If the doctor on the chart, on the day that they were brought into the hospital says, I believe that this patient is ill and is likely to cross 2 midnights, whether or not they do, Medicare may pay.
May, not shall pay. May pay.
Yeah.
So there's no guarantee.
There's no guarantee, but it's a better shot. So I encourage anyone who's in the hospital to ask their doctor just to write it on the chart, because a lot of doctors don't understand it either.
Right.
And so they're not doing it. And I did a lot of consultations for these kinds of admissions for about a year and a half, and trying to educate the doctors and trying to be proactive for the patients. And we saved a lot of patients a lot of heartache. And it's beneficial for the hospital, too. Right. The hospital wants you to be an inpatient, because in the end, they make more money.
Sure, of course.
So everyone wants to be an inpatient, but the government wants you to be under observation because it saves them money.
You've given us a lot of good information. I know you brought with you your 2 books. Can we talk about your 2 books? And first of all, what motivated you to write those books, and what's contained in those books? Sure.
Well, my first book was Medicare Essentials. A Physician Insider explains the fine print. A little winded, but it tells you that's coming from a trusted source. The book came about when I was doing my consulting with those hospitals in those admissions that we were just talking about. And I was getting very frustrated seeing that patients were stuck getting this observation status when clearly I was looking at their chart and seeing how sick they were.
Right, right.
So I wanted to educate them about how they could bypass that and get the government to pay a bigger portion of their bill. So Medicare Essentials started about the 2 midnight rule, and then expanded more and more. So I thought about all the things in my clinical practice that I saw patients get confused about. So it's kind of a how-to guide.
How-to, excellent.
Yeah.
Now you have a new book. Why don't we talk about your new book?
Sure. It's
The Idiot's Guide to Medicare.
Yeah. So this is a little bit more comprehensive, a little more of the finer details, whereas the first book is more of an easier how-to.
Okay.
So it talks a little bit more about how to pick plans, how to pick a good Medicare Advantage plan, how to pick a good Medicare Part D plan, and also about Medigap insurance, which is another thing that we haven't spoken about yet today.
Right. So tell us a little bit, what is Medigap insurance, and why should people consider that type of policy?
Sure. Medigap, despite the name, is not part of Medicare. It's a supplemental insurance that is meant to help people pay the deductibles if they are out of reach for them. So we mentioned if someone goes to the hospital, they pay a deductible of about $1,600. That's a lot of money.
Right.
Someone, say, who's really sick and goes to the hospital a lot, that can build up really quickly. Medigap insurance helps to pay down deductibles, premiums, and things of that nature.
Okay.
It doesn't help pay for other things, but for some folks it can be a big advantage if they're spending a lot of money on deductibles and that part of their care.
So you're saying that your second book is a little more detailed than your first book?
A little bit more details. It's a slightly different focus in terms of how to, more like a reference guide, like an encyclopedia.
So someone who's, let's say, a year or 6 months away from qualifying for Medicare, should they be reading your first or your second book?
They're both useful in different ways.
Okay. You're still treating patients?
Yeah.
And you're obviously having a good time with that?
Oh, you got to stay with patients. That's why I'm in this.
That's it. That's it. So you treat patients. You've written your books. You also have a website. Tell us about the website.
Yes. So diagnosislife.com. I started my website in 2008. It just started out when I was with patients in the clinic. They asked a lot of questions, and I found the same questions getting asked. So I started to just write little summary articles, and I said I got to put them somewhere rather than hand them out. So I designed my website, and over time it kind of evolved. And now I take a lot of big studies that may come out and kind of try and simplify them so people can kind of get the translation. And I like to kind of say, is this a valid study? Is it not? And share information.
Good place for us to stop. Today we learned that Medicare is the federal health insurance program for people who are 65 or older, as well as certain people with disabilities. Medicare was signed into law in July 1965 without any significant changes until President Bush signed the Medicare Modernization Act of 2003. This act added prescription drug coverage, which is known as Medicare Part D. As regards Obamacare, it is important to note that Medicare was not replaced by Obamacare. Dr. Feke shared with us that Medicare coverage is provided under 4 parts. Briefly stated, they are Part A, which covers inpatient hospital stays, care for a limited period of time in a skilled nursing facility, hospice care, and some health care, in-home care rather. Next is Part B, which covers certain doctor services, outpatient care, medical supplies, and preventive services. Then there's Part C, known as Medicare Advantage. It's a type of Medicare health plan offered by a private company that contracts with Medicare. Lastly, there's Part D, which provides prescription drug coverage. As you approach your retirement years, it will be crucial to understand Medicare. For example, it will be critical to understand when to enroll and what coverage will be best for you. Also, as a beneficiary of traditional Medicare, you will want to consider Medigap supplemental insurance plans to help cover deductibles, co-payments, and other gaps. Given that understanding Medicare can be a daunting undertaking, I strongly suggest reading Dr. Feke's new book, Idiot's Guide to Medicare. It's a must-read for every person seeking answers to their urgent Medicare questions. In closing, thanks to my guest, Dr. Tanya Feke.
Thank you.
Thank you. And as always, thank you to you, our viewers, for watching Your Money, Your Life. My name is Ramsey Bahrawy, Building Your Trust.